Hello and welcome. And today I'm very pleased to introduce Dr. Kate Russell, who is a GP who is going to help us in supporting a Ask Dr. Kate series where we go out to our talkhealth community to ask them to put forward any questions that they might like to ask a GP. So welcome, Kate.
Thank you. Thank you very much. And it's a real pleasure for me to be, invited to be part of this Talk Health community.
So before we start, what we do need to say is that Kate is unable to give specific advice to any of the questions that we might be discussing, because obviously we don't know people's background, what medication they might be on. And very much, I think also, Kate, we had a discussion before, but a GP's role quite often is because G stands for general. So the information you're able to provide is quite often on a general level.
Yes, I think that's, absolutely right. We certainly are generalists, and we're generally very proud of that. And as everyone's aware, our specialists are becoming even more specialists. So I think our role very much is as a first point of contact and as a signpost often as well.
Yeah, absolutely. So I was looking through the questions, Kate, and I know obviously you've got the questions that I put forward. We've had, interesting enough, because we're recording this in November and it is Movember month for men's health. And I do find it very interesting that the number of questions that we've had in from men. So to kick off with, one of our first questions was around fibromyalgia. Now, we do have a lot of people, I know we have a lot of members who do have fibromyalgia or something very similar to the symptoms that present with fibromyalgia, particularly things like with chronic fatigue syndrome and similar. And the question that was put forward to us, well, probably, Kate, it's probably better if I ask you to say in general terms what the question is.
Yes, that's fine. Actually, interestingly, it was interesting that this fibromyalgia question did come from a man, because generally we see it more in women. But the question was really around, the troublesome symptoms of being general fatigue, which is very common, along with stiffness and aching of the muscles and also disturbed sleep. And this question was very interesting because this gentleman was really saying that his symptoms had got significantly worse since he'd stopped sertraline. Now, sertraline is a type of antidepressant. And there is some evidence that various antidepressants can be effective in fibromyalgia or some of the symptoms of fibromyalgia. Obviously, antidepressants work on our neurotransmitters in the brain, and some of the same neurotransmitters are involved in the symptoms of fibromyalgia. So it makes sense that there might be some benefit from taking such a medication. And certainly what we know is the effectiveness of antidepressants with fibromyalgia is independent from any of their effect on any comorbid depression. So it has an independent benefit. This question was interesting because, I believe this gentleman was on sertraline for sort of general anxiety, and probably the benefits for the fibromyalgia were maybe coincidental. And I think the specific question was, should I restart? And I think for me as a GP, I think often, it's not often pure science, but if it was helpful for you, and since you've stopped it, your symptoms have escalated, I would very much say it's worth restarting. It's a very safe medication that you can take long term. But one interesting point, I think, specifically with this antidepressant, is it's maybe not the most helpful for fibromyalgia, and it might be worth having a discussion around some alternative medications, most of which, again, are antidepressants, but they can have dual action, or they can be from a different class, shall we say, and they act on several of the neurotransmitters in the brain, not just one. But I think obviously we always have to be very mindful of the side effect profile of some of these medications.
Absolutely. And we've a couple of months ago, we had a really interesting chat with some experts about when you go on to antidepressants, is actually what is your plan to come off them? To be thinking about them, you don't go on to them blankly and that's it. So I will put a link with this with one of our previous ones. But talking generally, about men's health at this time, is there anything else that you would add to men?
Yes, and I mean, as I say, we are in November, so this is very much Men's Health Awareness Month with very much a focus on mental health, and we're very aware that in general terms, men are a little more reluctant, shall we say, to seek help or treatment for their mental health struggles, and what we find an awful lot in general practice, and in exactly this scenario with this gentleman with fibromyalgia, that there is a real barrier still to accepting taking a medication which is listed as an antidepressant medication. So there is some stigma still around that that whole sort of mental health story, and I think there is a real challenge, particularly with fibromyalgia, to reassure sufferers that by prescribing an antidepressant, we're not saying that their symptoms are all psychological, that actually they're experiencing very real physical symptoms, but these symptoms probably do have some link with neurotransmitters in the brain. And I think a lot of people feel that they're being sort of slightly, slightly sort of fobbed off with perhaps more of a mental health diagnosis. But if you look at the antidepressants in general, they can be used for a number of, things. I mean, we've got bupropion, which is a very powerful stop smoking drug. We've got a lot of our antidepressants that we use for chronic pain, and some of our older antidepressants like, amitriptyline are really valuable for preventing migraines. So a lot of medication has dual use. And I think it's really important that we are very aware of some of the stigmas that surround some medications still.
Absolutely. And funny enough, moving on, well, not funnily enough, but moving on, but still keeping in the same sort of theme of men's health. The next question, I know somebody said that they were diagnosed with a varicocele, which affects their orgasms. Now, first of all, I have no idea what a varicocele is, and I may have mispronounced it.
No, you've done very well. Varicoceles are actually very common. We probably see them in about 15% of the general male population. Most of the time, they go unnoticed, to be honest. Obviously, again, on the theme of men's health, we are very encouraging of men to perform regular testicular self-examination. So often a man might feel a varicocele when undertaking some self-examination. They're often described as feeling like a bag of worms, and that is exactly what they do feel like. And they're actually an abnormal dilatation, so an abnormal swelling of the testicular veins. And so they're felt in the scrotum, but separate from the testicles. And as I say, they usually don't cause any symptoms. They are slightly more common in men who are experiencing some potential fertility issues with their partner. It's not sure whether that potentially is linked to perhaps a slight raise in temperature because of the increased blood flow. That's probably a little bit beyond this question. So I think, you know, in my knowledge, there is very limited evaluation or knowledge around the impact of varicocele on sexual functioning. As we say, we know there is the main focus has been around you know, couples with subfertility and possibly around erectile dysfunction. But in fact, the only sexual symptom which seems to have some significant association with varicocele is actually premature ejaculation. And obviously we're not entirely sure what exact issues are the question refers to, but generally looking at this question, I would ask, is this cause and effect? You know, it's quite likely that the varicocele might have been there for a long time, and it might not be a direct cause for any change in the sensation of orgasm. So it's a common problem that we have. What is cause and effect? It's something that we have to think about quite a lot, particularly in general practice when we deal with a whole range of quite non-specific symptoms. But we also know that one of the commonest symptoms with varicocele can be pain associated with ejaculation. And so therefore you might have a number of subtle, you know, psychological concerns which might affect the whole of sexual functioning. So it can be difficult to be very specific. The one thing I would just say is that occasionally we do see that, well, we know that there is a link between varicocele and chronic prostatitis, which is an inflammation of the prostate gland. And that, in this case, because of some of the sexual symptoms, that might just be something to consider.
And I suppose actually that will lead us on to the obvious question about screening. It's obviously relevant, particularly for November, about, you know, how important it is. And I know that we stress a lot on Talk Health is that people really should start screening from at least 50 onwards for prostate issues. Once again, we recently did a interview with Professor Neil Baum, who was saying, which I found really concerning, is that early prostate issues, there are no symptoms, which is obviously why it's so important. I don't know if there's anything that you would want to say, because I always feel that, you know, tests for, you know, the blood tests, they always seem to get quite a bad rap.
Yes, absolutely. And I mean, just, you know, just thinking back to what we said previously about prostatitis is not related to prostate cancer at all. And it's no evidence that it increases your risk of prostate cancer. I just want to be reassuring about that. But you're absolutely right. And I think it's quite exciting at the minute that there is some major new prostate cancer screening research you know, really in the pipeline. And, you know, it's really exciting when we think that maybe, you know, 1 in 8 men in this country are actually diagnosed with prostate cancer in their lifetime. And at this moment in time, there is no current screening program for prostate cancer in the UK. And that's really because the PSA blood test, so that's the prostate specific antigen blood test, which is usually the sort of first step towards a diagnosis, it's not nearly accurate enough as a primary screening test. And I don't want to get too bogged down into, you know, what a screening test needs to, what criteria they need to fulfill, but it needs to be sensitive enough to pick up cancer if it is there, and specific enough to pick up the cancer and not other things which are not as serious. So, you know, we're at the situation where the PSA test can miss a lot of prostate cancers and therefore give people false reassurance. And these might be people who would benefit from treatment. And it can also be raised when there is no prostate cancer. And that then results in people going through potentially quite invasive further investigations, and even overtreatment and the risk of serious side effects. So I say that PSA blood test has never really met the criteria as a screening test. Now, I get a lot of requests from men who don't have symptoms for a PSA blood test, and I will always agree to that. But I also give them some information about what might happen if the test was positive, and so because people have a screening test assuming it's going to come back negative and they're going to be reassured. And I think it's really important that that people do understand that if it comes back positive, then that is going to start a series of events.
So what would you suggest then? Would you suggest then that they, so we know that men should be aware and alert, and if there are no early symptoms, would you then suggest that they have a physical examination?
Without symptoms, probably not. I mean, if we brought every man in who wanted screening for a physical examination, I think that would probably keep general practice overwhelmed, really. So I think if you've got no symptoms, I think it's very reasonable to ask for a PSA blood test. And I think as long as you understand the limitations of the test, I think that is absolutely a reasonable thing to do. But I think what we have got, there's a quite a big randomized controlled trial going on at the minute called the Transform trial, and that's hoping to establish that various other testing strategies, and including using an MRI scan as an upfront screening test, is hopefully going to tip the balance in favor of a routine screening program in this country. So therefore, detecting disease that PSA testing alone would miss, and reducing the amount of insignificant disease that a PSA might pick up.
Gosh,
well, I think that's really exciting.
Yes, I mean, and let's hope that's positive, because as women, we have tests all the way through for various cancers, and you do feel that men get short shrift, and that they don't have that, one of the conditions that really does affect them. Yes. They don't have something equivalent.
Yes, and absolutely. And prostate cancer is a cancer that, we know if we get picked up early is absolutely treatable. So it's a really important one to pick up early, and yes, it is. When you're not having symptoms, it can be incredibly difficult to make those early diagnoses, and that's a real, early diagnosis of cancer is a massive. A massive focus, as it absolutely should be, for us in general practice.
Yeah, excellent. So, talking generally, actually, and thinking about the season, what are the most common things that people present to you in surgery?
Well, I think obviously at the minute, we are fully in our season of coughs and colds. And I think, we still see the impact of COVID and the concerns that understandably raised for people. And it has left us a really significant legacy of health anxiety. So I think what I've been seeing, particularly in surgery this last week, is a lot of persisting coughs. I think for a lot of us, we have a fairly standard cold, so a fairly standard viral infection, which affects our upper respiratory tract, so can affect our nose, our ears, our throat, and the upper part of our lungs. And most of the, the sort of the runny nose, the sore ears, the sore throat, they settle, but the cough persists. And that's when, you know, they see a lot of people have had a cough. It's gone on now 3 weeks. And one of the most common reasons people actually come to us with their cough is that it's keeping them awake at night, and it's actually disturbing the whole household. And that will be one of the main factors. But there is also anxiety around persisting cough and as a potential, again, you know, symptom of lung cancer, of which also there has, you know, fortunately been a lot of publicity over this last year for early detection. So, you know, I would say I am commonly seeing what is, you know, very much likely to be a post-infectious cough. It's gone on for 3 weeks. People are fed up with the symptoms and they come to us, often requesting something specific to treat it, whether that's antibiotics or something else, but also some reassurance that this doesn't signify something more serious underlying. So I think that's kept me quite busy this week.
So, I mean, I suppose I was going to say, and what would you offer to those people? Would you offer them some form of medication, or is it more just reassurance?
I mean, I think that, you know, I would always very much promote some support they can get from our pharmacists, for sure. You know, there is various symptomatic management around, you know, sort of over-the-counter preparations, which can be helpful. Obviously, I think there are a number of things which I'm always concerned about, and that is somebody, you know, obviously systemically unwell? So are they unwell in themselves? Have they got, you know, a high temperature? Are there any other symptoms which are causing me alarm? Or are they somebody who has other health issues which makes them much more at risk of complications? So those are the things that are very important for me to establish. In the short term, so if we're looking at a cough somewhere maybe that's been persisting for sort of, you know, more than 2 weeks, but not been going on for as long as 8, and 8 weeks is often my cutoff, and I think that's generally sort of we all, you know, we have to sort of sometimes have some arbitrary points where we think we need to investigate further now. So between that sort of, you know, 2 to 8 weeks, I think there are definitely some sort of self-help measures that we can advise people, often, as I say, through the pharmacist. Sometimes we might as well be looking at sometimes a short course of an inhaler, sometimes even a short course of a steroid, if symptoms are really causing, you know, a real functional impact for people. Generally, you know, I would try and encourage people that this is self-limiting, and it's very likely this will settle within that 8-week period. If not, yes, I would be very happy to see you again, you know, examine you and consider whether at that point some further investigations, possibly, you know, even including a chest X-ray, would be relevant. But there are a number of causes of a more chronic cough for longer than, you know, for more than those couple of months. And you know, we would definitely be keen to be, you know, questioning quite carefully about whether some other, not necessarily respiratory, so not necessarily lung related causes might be playing a part as well.
That's just me, who keeps trying to clear my throat at the moment. Yes,
it's a common problem.
Oh gosh, I have had it, and it is really frustrating, and I can understand why people do get concerned. But mine has definitely got better, so I know I'm on the up, so to speak. Anyway,
Good. I'm pleased to
thank
hear
you
that.
so much. It's been really interesting, and hopefully this will help some of our members with some of their questions, because I know we had wrapped up a number of items in other questions that we did also receive. At the bottom of this, wherever you'll be watching this, whether it's on YouTube, our podcast, or on the talkhealth platform, there will be a link which says Ask Dr. Kate. So if you do have some questions, and if you'd like Kate to have a look at them, and I can't promise that we will cover them, then please do submit them for next month. So thank you very much, Kate. Thank you.
Thank you. It's been a pleasure. Thank you.